welcome to this African Academy of Sciences webinar. So good morning to you all. Good evening to those of you whose day is coming to an end. This webinar is going to be for just about 1.5 hours. So we hope that all of you who've joined, which of course the attendance has been really good, we believe that you'll be with us until the end of this webinar. Let's set some ground rules before we proceed. So just to tell you that you're all on mute, and if you'll want to make a comment, there's a button where you need to click on to put up your hand, and then we will unmute you from here. If you want to comment on the chat, we really encourage this. Click on the comment button and leave a comment. And we are going to be recording all the comments and then using those particular comments in putting together the document that we are looking forward to be giving out after this webinar. And just to note that we may not be able to answer all the questions. So if we do not get to your question, we will still have it recorded and use it again for documentation purposes when we write out the outputs of this particular course. Okay, so I'll hand it over for to the Executive Director for the African Academy of Sciences for his official welcome before we begin. Thank you.
Thank you, Moses. Thank you, everyone who has joined from wherever you are. It might be good morning, good afternoon, or good evening. It's a pleasure really to have you on this first webinar for the African Academy of Sciences, and we are quite impressed with the interest that everyone has shown, because I can see that the numbers of people who are connected is increasing all the time. Let me just take this opportunity firstly to thank Peter for really coming up with this novel idea that we could have a webinar that could address this key issue as far as the African continent is concerned. From my team, I also want to thank Moses and the rest of the team that has been working on this in terms of preparations. I want to thank all the fellows, all our partners. I think I've seen someone from CEDA joining in. I want to thank all the colleagues that have made time to join to be part of this. This is a new way of doing business as far as we are concerned, obviously, because we feel, given the situation with the coronavirus, I think we need to continuously engage. We still need to find ways to address the concerns of people in the continent, even though I know that in some countries there's a lockdown. And ironically, I am actually in a government facility where I'm going through a compulsory quarantine since 2 days back. So it means that in Botswana, like anywhere else, I think people are quite serious about this. So I'm really looking forward to hearing what all of you are going to say. As Moses said, that we might not be able to address all the issues, but I think it'll be good to hear some of the points, even in written form. Just before I hand over to Moses, I just want to go through some of the objectives of this so that we can be clearly focused in terms of what we need to do. Moses, if I can have my next slide, please. Moses. So basically, I think we have got 4 objectives as far as this webinar is concerned. The first one, obviously, we want to define the areas of research which are of importance in the effort against COVID-19 outbreak that African scientists can contribute towards, because obviously Africa should depend upon its own scientists as far as possible. The second point is that we want to develop work streams for a science-based effort for the COVID-19 outbreak with clear mandates and targets. I think this will be a very important point, because then we can be able to monitor and see how we are making progress. The third point is that we want to identify otherwise unseen global gaps or opportunities that the African Academy of Sciences can assist as the lead organization, because of the fact that we see ourselves as the go-to organization in the continent, and we feel that we should play a very, very critical role in this instance. And the final point is that we want to develop scientific advisory units, whether focused on clinical, genetics, social science, human behavior, or global health, that can produce up-to-date information by African governments. I think we need to get this to policy so that African governments can be as prepared as they should be. With those few remarks, I look forward to the engagement. And Moses, back to you.
Thank you, Nelson, for that introduction. So this is our agenda for today. We are going to give the guest presenter, Professor Peter Olupot, 10 minutes to set the scene. And then after that, we've lined up some very interesting, distinguished, invited guests and panelists to give us their reaction to the presentation. And then after that, we'll go into an open discussion that is going to be moderated, led by our Director of Programs, Dr. Tom Kariuki, assisted by me. And then after that, we will develop our next steps in the remaining 30 minutes. So just as a reminder that we have put up some information on our webpage at the African Academy of Sciences webpage, so have a look. And if there's anything in there that you want to either question or comment on, please do so on this particular webinar so that we can be able to capture your comments towards the end. So with that, ladies and gentlemen, invited guests, I'd like to hand over to our presenter for today, Professor Peter Olupot.
Thank you very much, Moses, and thank you very much, African Academy of Sciences. I would like to start by requesting you to play the slides. Yes, I think they are quite skewed, but I've been introduced already, and let's straight away go to the business. Next slide. Yes, this is how the distribution of the epidemic is globally at the moment. This is as of 20th of March, it's about 1 week ago. There are now differences because there are new countries that have also registered cases. But all that I wanted to say is that the epidemic started from Asia, has swept through Europe, gone to the United States, and now it's coming down from the northern hemisphere down to the south to Africa. Most of the cases reported in Africa are imported cases, but they are now states and countries that are starting to report community transmission. Next. Yes, as you can see, this curve, it has two peaks. I don't see it properly here, but all that you can see is that there is a first peak which ends around February of 2020. And from around the first week of March, this is when the pandemic was declared, and the curve is still going in an exponential manner, meaning there are still more cases coming up. It has not yet leveled. And this has a lot of implications in terms of how Africa should respond to this pandemic. Next slide. Briefly, we need to do a lot of understanding in and around COVID-19. We need to expound on the current case definitions because of the limitations that are there. Currently, the case definition is limited to airway, but recent cases have also shown that the disease actually affects more systems than only the airway. For instance, the renal, abdominal, and cardiac. And those have not been included in the case definition. The other thing, even within the airway, cases are now reporting of sore throat well ahead of many things, including a fever. So we need to refine case definitions in light of that, and also in light of the fact that the risk factor, which is actually travel to the hotspot, is now being reversed by travel advisories and shutdown, which many countries are implementing. So those risk factors now are starting to change as the disease moves onto community transmission. And so is the pathophysiology. It's not well understood across geographical areas and across populations. And that also comes with the disease history. At the moment, we are giving a very wide range and say the onset of the disease happens and the symptoms appear anywhere between 2 days and 14 days. This is not good enough. We need to refine this so as to be very accurate with our screening and the case history of the disease. Next. Another thing which is extremely useful and important is to look at the diagnosis. At the moment, the accurate diagnosis is laboratory based. And in most African settings, there is only one centralized laboratory. And that laboratory is not yet even in position to develop a biobank. So what we would like to see happening is to evaluate the hub system, where a country has spots where they can get the samples, and these samples are shipped maybe on daily basis to a central laboratory that has a confirmatory test for an RNA virus, and then the results sent back to those centers where the suspected cases are quarantined. The other thing that is going to be of great use is taking the service to the people in the communities using mobile van laboratories. And through that, we should be collecting samples that go back to the central laboratory as biobanks. And in those biobanks, we now need to launch research for rapid diagnostic tests, evaluating the current suggested or proposed rapid diagnostic tests, and also validating the use of Gene Expert. The beauty about Gene Expert is that it has rolled out widely in Africa. But new information shows that it can actually be customized to do diagnosis for COVID-19. So we need to quickly show that this can happen in Africa and have as many people tested as possible. And the reason for testing is not just that we would like to catch people and give them the diagnosis. Countries that have done massive testing are able to quickly isolate the positive cases so that they are now able to check on the contacts and control the disease. So testing for COVID-19 particularly is useful for limiting the transmission of disease. Next. Next slide. Yes, so there are a number of non-drug interventions related to this outbreak that we need to look at. Where they have done lockdown, like in China and Italy, the peak or the epidemic curve quickly levels off and starts to fall. So we need to see whether models like that are useful in Africa, particularly seeing Kenya and Uganda and even Rwanda have quickly moved to partial lockdown. We want to see the impact of that and quickly get this information for countries that are yet experiencing their first or new cases. And so is the evaluation and validation of quarantine. How effective is it? For how long should quarantine be? The current 14 days might actually be too short a period, or it could even be too long. So we need to validate the quarantine based on both the diagnosis and the rate at which patients shed the virus. Then social distancing. This is a very interesting area of research. It is not just about social research, but there is new information coming to say or to indicate that viral load is actually a determinant of who gets infected and then how severe the disease will be. So social distancing in relation to acquisition and transmission of disease is going to be extremely useful in terms of controlling this, and we need to validate that. And then the communication, which is related to the control of COVID, requires to be validated quickly. What type of information do communities receive and quickly apply so that we roll out this to the communities that deserve them, and even which are the channels that the communities use to access information. This also needs to be put in place as quickly as possible. Next slide, please. Yes, so in terms of drug interventions and vaccine trials, we actually need to do multi-purpose trials. For instance, a complex trial which is designed for multi-site to support validation of candidate drugs, candidate vaccine, adjuvant therapies, and supportive therapies. Factorial designs are of great importance in this direction so that one trial is able to solve many problems at the same cost. Going by each of these trials individually is not only costly, but delays interventions to come on board as far as this disease is concerned. So we need to promote interventions that are multi-purpose, all-encompassing, so that one trial is cost-effective to bring in interventions that we need in a short period of time. Next slide, please. Then briefly, I think you moved to this one on community engagement. Yes, looking at community engagement and social science, we need to quickly build this into the system and validate or evaluate community engagement criteria and make the communities be part of the solution of COVID-19. Then the other one is we need comprehensive social science that will now take communication and social engagement into the future. Again, this is an area that we need to develop succinctly to help nations cope with COVID-19. Next slide, please. And in terms of ethics of COVID, we know most of the research is going to be in an emergency setting. We need now to quickly have guidelines that enable research get out there as quickly as possible while not compromising consent, biobanking, genetic research, and if possible, ethical guidelines on single and multi-site research is required at this particular stage so that we are able to get this out there as quickly as possible. Next. Yes, so in terms of outcomes of our meeting, one, we really need to be able to map out ongoing research and development work in Africa. A lot of scientists have got into action, but then their work remains disaggregated and uncoordinated. So we need to map out who is doing what in Africa so that we feed all this system, all this data into the system to help our continent. In terms of evaluation of anticipated spread models, we again need to validate this as quickly as possible so that we know the model which is responsible for the spread of disease in Africa. The model in Europe and Asia and America may not necessarily be the one for Africa. For instance, most of the imported infection in Africa is quickly getting into community transmission. So we really need to have models that take care of that in Africa so as to inform guidelines. In terms of evaluation of the impact on the control measures, one, we need first to look at the impact on COVID itself, but also the current interventions, including use of sanitizers, washing of hands, protection, using masks, and so on other infectious diseases, including diarrheal diseases, pneumonias, and so on. So we need to see that to evaluate that what these interventions have on those other diseases. Then, of course, acceleration of evaluation of interventions, like I've already mentioned, structured and fractional designs should be supported in this sort of work. Then, of course, supporting African scientists and innovators is going to be extremely useful. So having mapped their work, we really need to support and take on potential studies to the future. And then, of course, protection of at-risk and vulnerable groups, including pregnant mothers and neonates. We yet don't have data on the impact and effect of COVID-19 on pregnancy and pregnancy outcomes. So we quickly need to check on this, and so are prisoners. Remember, prisons are crowded places. So we need to look at this as quickly as possible as we look onto the disease risks and outcomes in all age groups. And then we need to look at examples of work going forward, particularly there are a few slides that I've put. Next slide. That is one of the studies that I am piloting. It is actually an open cohort study, which is an online based and supposed to inform on the case definitions and epidemiology of the disease. We intend to enroll up to 5,000 respondents in a cross-sectional survey that we shall now use to pick on study participants that will go on to the cohort study for 12 months. And during that time, we shall be able to analyze data from time to time and be able to feed back into the situation of COVID in Africa. Next slide. Next slide. Or it's taking long. But the next slide is actually, just before that, next slide is actually the one talking about having knowledge translation. We have some data coming out from South Africa, from Kenya, from Uganda, from Rwanda. We need now to get this and synthesize it in the knowledge translation model for health, social works, economics, security, and regional integration, so as to have a well-guided intervention in the whole of the continent to respond to this. So this is basically what I'm talking about, but there are other interventions that other sciences are doing, and we need to see how to support this, taking our continent forward in terms of response to COVID-19. I need to caution that when HIV/AIDS came, actually it took Africa by surprise. We've had some small window of opportunity to know that the epidemic or the pandemic is coming into Africa from Asia, Europe, and Africa. So now we need to be extremely prepared, and I strongly feel that equipping scientists and taking this science forward is one way to help the continent respond to this. Finally, I think I hand over to Moses to invite the panelists to make some reactions on this presentation. Thank you very much, Moses.
Okay, so thank you so much, Professor Peter Olupot, for that scene setting. For the reactions to this particular presentation, we've assembled for you a distinguished panel that is composed of 4 high-ranking individuals in global health, whom we are just about to hear. The first is going to be Dr. Richard Hatchett from the Coalition for Epidemic Preparedness and Innovations. And then after that, we are going to have Dr. Tariro Makatsange, Director of Biology at Gilead Sciences. And then we'll follow that with comments from Dr. Henry Mwandumba from Malawi Liverpool Wellcome Research Program. And lastly, we will have Professor Kevin Marsh, a special advisor of the African Academy of Sciences and also from the University of Oxford. So Dr. Richard Hatchett, we know that we invited you on short notice to actually attend, and we are quite happy that you've made time to actually be with us. So for the few minutes that you are able to comment, what from CEPI's point of view, what are those important things that we as African scientists need to just be aware of as we proceed with this particular initiative?
Sure. And Moses, can you hear me okay?
Yes, we can. Thank you, Richard.
Excellent. Thank you, and Peter, thank you for those scene-setting remarks, and thank you to the African Academy of Sciences for the invitation. My name is Richard Hatchett. I'm the CEO at the Coalition for Epidemic Preparedness Initiatives, and we are focused on developing vaccines against COVID-19. Our goals in developing those vaccines are basically focused on speed, scale, to be able to produce them in large quantities, and to ensure global access. Sorry about that. I had a call coming in. I want to say the comments that Peter made, there are a number of important elements to highlight. I think the criticality of understanding the social distancing interventions, the behavioral sciences component, particularly in an African context, how to engage communities, how communities can adapt in an environment where COVID-19 is circulating, absolutely critical. And I want to focus my comments, however, on thinking about the potential availability of vaccines. Our goal is to deliver vaccines. We hope this will be unprecedented if we can do it, but it is our target within 12 to 18 months. When the vaccines become available, They will initially be available in limited supply, and so undoubtedly they will have to be prioritized. And I think understanding one challenge for African scientists now, as they protect their communities now, but also as they prepare those communities to receive these vaccine products, it's going to be very important to understand who in African society is at greatest risk, who the vulnerable groups are, and to think about how vaccine products can be delivered to them most efficiently. Prior to the availability of vaccines outside of clinical trials, there will undoubtedly be a need to perform evaluations of those vaccines in the African context. We are in the process, working with our vaccine development partners, beginning to think about clinical development plans, and that will include clinical trials in multiple regions around the world, to include Africa. And so we will be looking for partners in the African context. I think the final thing to think about, and again, this goes back to the identification of vulnerable groups. The initial epidemiology that we have certainly have identified the elderly as a general population group, and some medical conditions as being important determinants of risk. It does appear that males are having worse outcomes than females overall. I think understanding the impact of the disease and with the greatest specificity possible on African populations and in different regions of Africa will be absolutely critical. We would welcome the opportunity to collaborate with African scientists and clinicians and clinical scientists, and look forward to working with you over the next year to 18 months as we try to bring these vaccines into play. Over.
So thank you so much, Richard, for those comments. Before you go, Richard, how far away do you think we are from having a vaccine on the African continent?
Well, I'm very encouraged, and I'm very pleased to report that the first of the vaccines that we are supporting, a vaccine made by a company called Moderna, entered clinical trials in the United States on March 16th. That was only 9.5 weeks after the release of the genetic sequences, and I do think sets a new record. We've been working very closely with US NIH on that. We have a number of other vaccines that will be entering clinical trials really starting in April into May and the early summer, and some of those vaccines will be ready for phase 2 clinical trials, certainly we hope in the summer or early fall. And I think beginning to think about the potential for clinical trials in an African context, I'd have to talk with my director of vaccine development about specific timing, but I would think in the fall that might be possible. So we should initiate discussions pretty soon, I would think. Over.
Good. Thank you. Thank you so much, Richard. I know that you need to run to your next meeting, but thanks again for making time to be with us during this particular time.
Thank you for the opportunity. Really appreciate it. Take care.
Okay, thanks. Thank you. So the next comments we are going to be receiving from Dr. Tariro Makatsange. I hope I pronounced that right, Tariro. Who is Director of Biology at Gilead Sciences. We know that Gilead has been working on probably the drug with the best promise so far, remdesivir, for this particular infection. Tariro, how do you see this particular epidemic, unfolding on the African continent, and what are some of those things that we just need to be on the lookout for as we work with various different partners across the globe?
Great. Thank you, Moses. Thank you for this opportunity to speak with you. I think just up front, just to say that I am speaking to you on an individual capacity as an African physician scientist, so not so much representing Gilead in this context. So I think I'd like to echo everything that has been said already. I think the professor sort of touched on it appropriately. and the call for supporting vaccine trials, I think, is going to be very important. I think if I could just briefly sort of mention what I think will be the key priorities in terms of the African response, I sort of see it falling into three categories. The first is around the strategies that we're all taking right now around non-pharmacological interventions, so thinking about containment and mitigation. I think there's a lot of opportunities for research around public health interventions for this kind of epidemic. I think in the global environment we live in, there is a substantial possibility that there will be a SARS-CoV-3. So the lessons learned from this and appropriate planning and implementation of public health strategies will be important. So engaging in that kind of research and engaging in modeling the impacts of those kinds of activities will be important. The second is around testing. I think the challenges that we're facing right now around testing in Africa are largely driven by significant reliance on commercially available tests, whether it's Cepheid or Roche based testing. So research around developing internal capacity around testing, developing antigen-based rapid self-administered tests, as well as PCR-based tests that can allow for self-collection and rapid dissemination of results. This can be done leveraging a lot of the networks and capabilities that have been established for HIV, and I think there's significant potential for research on the continent around not only the science of developing the tests, but the implementation science around deployment and effective use of tests. Then lastly, my last comment would be on treatment and clinical trials. And I think the professor touched on it appropriately. A key thing that is a challenge with doing clinical trials research are bottlenecks around rapid implementation of protocols. But in this scenario, we do need to fast track that, enable the repurposing of drugs, well thought through, well controlled clinical trials that can guide local clinical management, as well as combination strategies that could be effective for dealing with a disease that is both driven by the virus, but also driven by the host response to the virus. As well as mentioned by the last speaker, enabling partnerships with pharmaceutical companies, vaccine development companies to allow the rapid testing of potential therapeutic agents in our local context. Then lastly, I would just say that there is an opportunity to really understand the role that comorbid infections will have with this type of respiratory infection, in particular in some of our regions in Zimbabwe and Southern Africa, where there's, well, throughout the continent, where there's a huge burden of HIV, TB comorbidity, and other comorbidities that may have significant impacts on disease management as well as clinical outcomes. So the scope of clinical research work that will need to be done is very high. And as people prepare for responding to the epidemic, this is the right time to be planning and preparing for being able to engage in those types of studies and inform a continent-wide, region-wide approach to management and enabling good outcomes. So those are the three main areas that I think there is a potential role for significant research input, and happy to stay on and answer any questions or comments.
Brilliant. Thanks, Dorito. So just because we have you on the line, and even with the caveat that you put on the table before you started speaking, would you have any comment on remdesivir for us, or chloroquine for that matter, or tocilizumab, the IL-6 inhibitor that is currently being used for the cytokine storm in severely, ill patients?
Sure. So I can make some brief comments. So in terms of the acute phase of the response to the epidemic, so we had somebody talk about vaccines. Vaccines will be long-term, so of an 18-month type of solution. A much more immediate solution is finding effective antivirals. And the approach that ourselves and many others are taking has been to identify antivirals that we know have good efficacy against similar viruses, so whether it's things like SARS or MERS, or screening huge libraries to identify novel chemical entities that potentially could have activity. Remdesivir, as you all know, is a medication that was tested in the Ebola crisis and was used in that context, and has now been is now being used for evaluating its efficacy in the context of SARS-CoV-2. As you all know, the drug is in clinical trials. There are 2 ongoing clinical trials of the agent in patients with mild and moderate disease in one study, another in patients with severe disease, as well as several studies that have opened in partnership with the NIH, as well as Gilead-sponsored studies that are taking place globally in the United States, Europe, and other Asia and other centers. The data from the remdesivir trial is not yet available, so I cannot comment at all on its efficacy because nobody knows its efficacy at this point. And that data is anticipated to be available in April. So over the next few weeks, we should have some initial data from those studies. But at this time, for any pharmacologic agent, it's really important that well-designed clinical trials are done to give us a good sense of whether the agent has activity or not. On your second question on chloroquine and hydroxychloroquine, the in vitro data does suggest that these agents have antiviral activity, and so have been in an effort to try and provide some therapeutic support to individuals, have been used. Much of the data, unfortunately, is anecdotal. We do not have good controlled clinical trials assessing its efficacy, though there are several trials ongoing across the board, across the globe, to try and further evaluate those agents. The combination of hydroxychloroquine and azithromycin, as you know, was published. Again, mostly anecdotal data, not the most rigorous study conditions. However, the hypothesis of combining an antiviral with a macrolide that has anti-inflammatory properties is a reasonable hypothesis, and better quality data needs to be generated. Then lastly, on IL-6, again, I think the challenge with this virus is not only the virus itself, but the inflammatory response that is stimulated in response to the virus, and that contributes to the pathophysiology that we see with progression to ARDS and subsequent organ system failure. So again, it's a reasonable hypothesis, and further clinical trial data should shed some light on its applicability in an acute clinical context.
Brilliant. Brilliant. Thank you. Thank you so much, Tariro, for those comments. I think it, in a way, lays some ground for us to be able to stand on when we are thinking about various different clinical trials that we need to design at this particular early stage, before the outbreak actually takes hold within the African continent. So our next commenter is Dr. Henry Mwandumba, Professor of Medicine and Deputy Director of the Malawi Liverpool Wellcome Research Program, immunologist, and President of the Federation of African Immunological Societies. So Henry, maybe just give us your comments and then and reactions to the presentation that Professor Peter Olupoto gave us before we proceed. Where's my time? Just checking again, Henry, if you're there. Okay, so as we search for Professor Henry Mwandumba, I'll go to our last panelist, Professor Kevin Marsh, really asking the question, so what next? What next for Africa? It seems as if we are standing at the precipice, a cliff. Before we jump, what is it that we just need to keep in mind?
Thanks, Moses. Can I just check that you can hear me okay?
Yes, we can. Thank you, Kevin.
Okay, well, thanks. And thanks for arranging this, and to Pete for giving the opening. I'm sorry not to be with you all in Nairobi as usually would be, but obviously, for obvious reasons, somewhat marooned in the UK at the moment. Well, I think it's really daunting when faced with such a massive problem to know where to begin. And I think the key thing is we need to be really focused, and we shouldn't make matters worse by wasting time and duplicating efforts and engaging in many of the kind of behaviours that I'm afraid, as research communities, we often engage in. So I think a real priority is real-time transparency in knowing what's going on. Now, several people have already mentioned this, and I just wanted to flag that I know that, for instance, UK CDR have been spearheading an effort to bring together information on all COVID-funded activities, research activities, into a database. I also know that the director, Marta Tupper, is on this call, so it would be very good, perhaps in the questions, to ensure that African data can be put on in real time, because I think it's absolutely key we don't duplicate and that we know what's going on. So that's an overall comment. I think all the research priorities that have been mentioned both in the briefing document and by my colleagues are all important. I just want to mention or flag three and then a fourth overall one. First, it's absolutely essential that we know how much transmission is taking place. Now, this may seem obvious to say, but unfortunately, many countries, many European countries in particular, have been really behind the curve on this. So we need, in all African countries, we need rapid, planned surveillance, ideally with shared agreed protocols so that data are comparable. And one model would obviously be to do population surveys based around areas of known cases and then control areas, because there are two possibilities, well, there are many possibilities, but it may be that there's far more transmission than we already aware of. It may be that there's very little transmission. Whichever the case, it's essential we know this now, because epidemiological description is the basis of everything else which is done. So this is really essential. And again, I repeat again the issue of if we can develop shared protocols which are implemented quickly and rigorously, that would be a good starting point. Secondly, we do need to feed the emerging data from these kind of surveys into models, but what we should avoid is the situation which again has been all too common in the past of investigators working with favoured groups and keeping the data sort of away from everybody else. This is too urgent. I think all the data needs to be made available in real time to any modelling group so that different approaches can be taken. Now, obviously, this does mean there needs to be some governance around this, but I think transparency and sharing is an absolute priority. The third priority is an obvious one, which has already been referred to by several colleagues, so I won't say much about it, and that is that the need to set up large and pragmatic trials, both for treatment and potential prevention, both drugs and vaccines and other interventions. I think where possible, these should be in densely populated areas partly because that's where the biggest problems are likely to be, hard to ensure social distancing, etc., and also obviously for numbers. But I think these need to be prepared for right now, even without knowing the specific intervention. I think, and again, the issue of shared protocols, shared easily adaptable protocols is important here. And then finally, and again, this has been mentioned, but I think we should stress it, and we should ideally during the discussion come to some sort of way forward on this. We just can't do ethical review in the way that many of us unfortunately have got used to in many of the countries we work in. We need to be able to get ethical review done in days, not weeks or months. And this needs to be done without losing any rigor. And one possibility, because clearly it is an emergency, but that doesn't mean that one doesn't need to put great emphasis on the ethics, both the science and the ethics. I mean, bad science is bad ethics. One possibility is to for consideration is to establish a credible full-time expert group drawn from across the continent and potentially with others, whose would work full-time and whose decisions would be accepted by other ethical committees. We're all used to the idea where protocols go through multiple ethical committees. This is just not going to be, well, it's possible, but if it happens, it's going to delay absolutely everything. So I think we've got to pay some real attention to how we do very fast but very rigorous ethical review. So they're my overall comments, Moses. Thanks very much.
Thank you. Thank you so much, Kevin, for those comments. And just to pick on one of the points that you've put on the table about, a properly coordinated effort, and give some bit of information to the team on the call. We are not working alone in this. We are working very closely with the WHO, of course, WHO Afro. Honorable Masitiso's Moeti's office. And then also we are working very closely with the AU and Africa CDC with John Nkevasong, and we are linked to the task force that he formed at the beginning of February, focusing on various different things. But to really put us in focus in terms of what we need to do as African scientists, I'll invite Dr. Tom Kariuki in a way to set the stage for the discussions that are going to come after this, and just point out what is our current competitive advantage as African scientists, and how can we move together as we look at this threat to our current generation. Professor Tom Kariuki. Thank you. Sorry, Tom. Yeah, you're now on mute. Yes, we can.
Okay. Right. I suppose it's very good initially to see and to hear all the what has been shared in the beginning. I think this is great to hear from the panelists and the speakers. We've been thinking, as Moses has said, that we need to find a way of moving forward. I think what is would be interesting to ask you, Moses, is how much time we have for some comments before I go to some sort of way forward comments that I would like to share with the entire group. So when I come back to you and ask whether you want us to open this to a little bit more of people who may have inputs, I think that would be useful to do that. And then let me know when I can come in with a bit of some summaries of what we want to put forward, moving forward, as we think about all the brilliant agendas and proposals that we are hearing from.
Okay, so that's right, Tom. We are in good time. We've got 40 minutes to the end of the call. That gives us that gives you a bit of time to make some initial comments, and then after that we will open up the call to anyone who wants to make a comment. For you to make a comment, just click on the hand button on the webinar link. And then after that, we will unmute you, and you can be able to either make your comment or ask a question. And then after that, the last 15 minutes, we will again come back to Professor Tom Kariuki for some next steps as we build towards our advisory paper that is going to come out after this particular call. So back to you, Professor Tom Kariuki.
Okay, all right. So let me just start with what has been reiterated by the group here, that we don't seem to be getting any pandemic sort of heartening news. Everything is grim news from anyone, from country, from across the continent and globally. How our African countries are tracking new cases and patients with COVID-19 over the last few weeks, and how we track things moving forward, I think has been really emphasized by the team and the panelists and the speakers who has gone before. I think it is good for us to always remind ourselves of the globally sobering statistics that essentially for COVID cases in every country now is confirmed, almost all countries around the world. We should remind ourselves that 65 days it took 65 days to go from 1 0 case at Wuhan to 100,000 confirmed cases. 11 days took us from 100,000 to 200,000 confirmed cases, and just 4 days for us to go from 200,000 to 300,000 confirmed cases. And as of today, when I've checked the numbers, is 487,000 and 22,000 dead. Now, Peter and the speakers have really emphasized the need for us to get into data modeling on case definitions and case fatalities. How does Africa stem and avoid the exponential curve, avoid the peak? How do we aim to flatten and tail off the curve? If there are 100 people who are infected, do we know how many will have asymptomatic or mild infection that can be managed here in Africa? Do we have an idea whether it is 60 or 80% in Africa that will have mild infection? Do we know what really means for the 40 to 20% who will need probably hospital care and needed critical care? I think globally, the case fatality rates could be around, for discussion, around 0.5% overall, or less for regions with access to good healthcare like Africa. So the big question for Africa is, without access to good healthcare, could we be staring at more than 5% fatalities? So and that's the question I think we need to put out there and get more information on this. Then this brings us to the question of health systems. If Africa becomes the next epicenter of the pandemic, as Peter has sort of mentioned, our health systems cannot cope with these numbers. How long each part of the curve lasts, how high the peak and how long the tail of the epidemic, all depends on what is done in Africa and the constant context where the epidemic is unfolding. So I have had a very good somebody mentioned that there is no one curve that fits everywhere. So the curve for this disease in China could be different from the curve in Europe, could be different from the curve in Africa. So there's no one curve that fits everywhere. So we are now into lockdowns and draconian measures that are being put out by governments across China, Europe, India, and now Africa. So we are introducing these draconian measures to try and reduce the impact and keep the peak below the level at which the health systems and society will collapse. And I use that word, the chance of collapse. Will this work in Africa? If this does not work, the impact on individuals, on communities, the impact on society is unknown. And consequences are clear at both of two fronts. There is the social and there is the socio-economic issues, and I would dare say that there are even political consequences in Africa that we should be aware of this. We need data, as Kevin has said. We need data as impact will presumably depend on how long the pandemic lasts, how much people will trust actions of governments, and how people will see actions that are equitable, that they can embrace across all our societies. Let me focus a little bit on some research questions, and I am throwing them out there, and hoping we can get some questions really confirmed as a way forward, even as we get some inputs. One, the question of modeling approximate curves. We need to get into that question of how we model approximate curves for Africa. Can scientists from this group who can use and share approximate curves for Africa? The question is, are we likely to get to 6 to 8 weeks for acceleration and peak of COVID disease in Africa? What is the period? 6 to 8, 10 to 12? More than that? 2, products. And I think this has been, addressed by Tariro and by Richard Hatchett. The first volunteers received a potential vaccine as part of phase 1 study developed by Moderna company and funded by NIH and CEPI. What is the chance that future clinical trials can be done in Africa? This is something we want to get more into. Here at the academy, we are building a CTC, what we call a clinical trials community platform that can provide information on to evaluate potential therapies for how global COVID-19 pandemic is done, so that a sense of urgency really develops, so that we get a one-stop comprehensive source of information for operational logistics and to conduct clinical trials in Africa. So if we get into clinical trials, we are interested to know if there are African researchers and institutions who are participating in planned or rolled out randomized controlled trials for treatments, or randomized controlled trials for vaccines, for diagnostics, medical devices that are required for this pandemic. On the issue of treatment trials for the various drugs, so I have heard from Tariro about the use of antivirals, and purpose drugs are quickly needed. Some in clinical trials is good news. I think it's important is for us to get into global solidarity treatment trials that are coordinated by, for example, the WHO. There's a R&D blueprint, which will start, I hear, this week or very quickly. Additionally, I think there's also a global solidarity prevention trial for care workers. We will start in a few weeks that are linked to WHO. There's a need for the therapeutics accelerator. We need to be able to put African researchers in touch with these global WHO, and I would mention probably getting in touch with Deputy Director Sumia with how we then work on potential trials and products. A key issue is diagnostics, testing, surveillance. This will be massively required in Africa. We remember all of us from the message from Tedros that we must get into testing, and more testing. And we need 2 kinds of diagnostics. One is the available kits from Peter mentioned around viral detection, from whether they are available from outside organizations, Roche, KFAID, etc. But we also need available rapid kits for undetected infected persons using either antibody or serology targets, because we need, as mentioned, to define exposure, look at age stratification, old versus young, gender, vulnerable groups. We don't have actually the technology to do that. So the evidence of past infection is crucial, because that is how we understand the epidemiology of this pandemic. So the question, I guess, is asking to all of us as African researchers is who is working on diagnostics in Africa? And I had invited Amadou Sall of Institut Pasteur in Senegal, and he was not able to join. But this is something I think we need to understand exactly where some hubs are doing across the continent. I have a question around, for example, the virus sequencing and genomics. Can we hear about facilities in Africa capable or already carrying out the virus sequencing? We need genomics to track the virus, mutations, data for designing interventions are needed, or they need genomics. And in all these areas of research, we need data shared in real time, as Kevin has emphasized. Then we have a question around technology and policy advice. So we need to advise governments for how Now we are migrating from offices to our homes. As lockdowns are announced, will this work for every country in Africa given the levels of technologies? In Kenya, for example, the AAS is hosted here in Kenya. The main technology, the virtual platforms are working well with inevitable teething problems and switch-offs. Extraordinary advice needs to be given to governments to invest more into digital platforms on how to achieve home working or homeschooling, the extraordinary efforts needed for health and for the economy itself. So finally, let me stop by saying one final things. One, we need to get into concerted global efforts. So for Africa and for global efforts, we need to be well hooked, linked to our own African global efforts. So for example, how we work with Africa CDC, how we work with WHO Afro, how we work with country level for CDCs. Global funders and foundations, AMF and World Bank has announced funds to low and middle income countries. I hear the G20 are getting together with the G20 focus. Do you know whether they're going only to be focused on their own countries or are focused globally? We need to focus on systems that can address issues such as PPE, ventilators, masks, other basics for hospitals. The logistic and supply chains are getting really pushed down. So public health and for AAS, we are very keen on R&D agenda. Let's not forget mental health issues. So with CP and PDPs like FIND, DNDI, the focus on vaccines, testing, drugs, all of that is something very important. And mostly social science networks on community interventions and how we build trust. As we have previously learned from the Ebola crisis in Africa, the need for us to build social science networks. So finally, I think for the AAS, we are very keen to hear from how we build this network coordinated for this work as proposed. And we're recommending also that all the institutions across the continent, we all think about strategy, about the commitments we have to do. We think about the obligations that we have for each country in each place. We think about the controls. We think about we engage with the external communities, and we think about how we put everything in place until the pandemic is overcome. Let me stop there, and I think we'll be very keen to get some people give us their inputs into all of these areas.
So thank you so much, Professor Tom Kariuki. We currently have one hand up, and just looking for the name, Amos Mohone. So Amos, we are just about to give you an opportunity to ask your question. We have three questions. So Amos Mohone, then Amos La, then we have Claudius Mahiti, and then Moses Bokari. And then just to notify Christian Happy, we've seen you on the line. So after the initial burst of 4 questions, we'll give you an opportunity to also give a comment. So go on, Amos Mohone.
All right, thank you. Actually, my question is basing on the therapeutic option of this virus. Dr. Tariro made a comment on hydrochloroquine and azithromycin, which to me, I think it wasn't that clear or not, because the recent one of the recent clinical trials which was done, of course, they used few number of individuals, that was 36, but it showed pretty good that a number of them, most of them, actually were getting better with this combination. So I just wanted the clarification: what is the actual problem with this? Is it the trial, or is it its mode of action with this combination? What is the problem exactly? Because it didn't come out clearly to me when she was explaining about what are some of the problems of this. So probably if she can a bit explain more on this, what is the problem with this therapeutic option?
Thank you, Amos. Tariro, would you like to take this now or a bit later?
Sure, I certainly can. So I think that the simplest way to think about this is sort of along the lines of the early days of HIV. We were very keen to help patients and to do something for patients. So trying as much as we can with what was available and what was on hand. As I said, the evidence is very weak. So if you look at the papers, it's not a very convincing trial with a very mixed population. However, there is some in vitro activity of chloroquine and hydroxychloroquine that it is a reasonable thing to do at this point until there is sufficient evidence to guide otherwise. And obviously doing that in a safe approach is important. However, at this point in time, there are no clear antivirals with efficacy that have been shown to have efficacy against SARS-CoV-2, and that's pretty clear. However, there is this type of anecdotal evidence. So everything that you've mentioned is anecdotal evidence. And typically in clinical medicine, we do try to have more rigorous evidence in support of an intervention. However, in the setting where there are limited clinical options, this is what we do as physicians. We try to help patients with what is available to us, and that's why people are grabbing onto that until we get good clinical trial evidence for its efficacy. I hope that helps to clarify.
Yeah. Thank you so much, Tariro. I guess so that again we are not stuck in the science and the biology. It will be important to also think about what we need to do going forward. Really, this was the intention of this particular call. There's always an opportunity for us to discuss the science going forward. But if we are to do something for our public health workforce, if we are to propose some initiatives around the systems that can be able to find every suspected case, or if we are to do something around production capacity and availability of testing, then how we help our governments to actually come up with the correct strategies for this particular disease. I think those it's towards our objectives that I'm trying to push everyone towards. So if we are asking questions, please let's try and focus on these kind of areas, especially proposals and people who are already working with the various different initiatives of the continent on COVID-19. It will be nice to hear from you. So Christian Happy, we know that you've done some work in Nigeria on some of the first patients on COVID, especially from a diagnosis point of view. It's your opportunity to give us your comment. And find Happy on this line. So as we continue looking for Christian Happy, we'll give an opportunity to, it was Amos La, to ask his question. Amos La, go on if you're ready.
Hello, can you hear me?
Yes, we can. Go on.
Okay, thank you very much. My name is Emosla. I work for the University of Ghana here in Accra. First of all, I would like to thank the African Academy of Sciences for the opportunity to learn from the experts that they have assembled and also to share. I'm particularly happy that the presenters and the panelists have addressed a number of important issues, including, for example, ethics. I am a bioethicist at the School of Public Health here in Accra. They have touched on that important topic of facilitating or fast-tracking review of proposals in an era like this, which I appreciate. But I would want to note that beyond just research ethics, I think there are several ethical issues associated with pandemics, just beyond research. And I think we also need to be putting priority to those issues. And so, for example, several commentators have commented on preparedness plans, especially for those in the developed world, and then their responses. In those developed world where plans exist and have been critiqued, they are still having very serious ethical challenges in the face of this pandemic. How much more our setting in Africa where the plans have not been critiqued or they do not exist at all. And so, for example, in 2015, we assessed the ethics sensitivity of Ghana's preparedness plan for a future pandemic and identified a number of important ethical issues that the drafters of the plan had not anticipated, have not acknowledged, and therefore hadn't addressed in their plan. They included what we are experiencing right now. For example, absence of guidelines to provide guidance to those who would allocate scarce resources during pandemics. Inactions relating to stockpiling personal protective equipment, as we are experiencing now. And we believe it wasn't just Ghana, but several other African countries have no plans. Those that have plans haven't actually been critiqued. And so as we talk about efforts to address the current pandemic, I think as far as ethics is concerned, in addition to the research ethics, let's also look at professional ethics, ethics during this response, and ethics even beyond the response. And so I would plead with the conveners of this webinar to give maybe the advisory units that are being created. 4 or 3 have been mentioned already. It may be a good idea to have ethics advisory unit created as one of the response measures that are being put forward. Thank you.
For those comments. I'll give an opportunity to Professor Peter Olupot and then Professor Kevin Marsh to just give a comment about ethics, professional ethics, and also ethics review committees, and back to the idea that Kevin had initially proposed, having mutually acceptable ethics committee that can be able to, in a way, fast track the ethics reviews and approvals that we need for us to keep moving. So, Peter, I know that you got your ethics approval for your study quite quickly. Would you mind giving some comments on this one?
Yes, Moses, thank you once again. And I want first to refer to that study. It is an open cohort study, which is meant to collect data online and is going to reach out to people through social media, through emails, and people click on the link and then they start at the screening phase, then they go to the consent, and eventually they answer questions. Hopefully we shall gather as much information as possible that will enable us to characterize epidemiology and also case definitions of COVID-19. But as a matter of fact, we had to write a separate letter to the Research Ethics Committee and let them know that it's very important to fast track this because it's a response by scientists to the call to refine case definitions and advance epidemiology. So the awareness about fast tracking ethical reviews is still not there. So maybe I would call upon our scientists to engage with our ethical review committees and ensure that they are aware that we need to fast track some of these protocols. In Uganda, we now have a system which was launched only yesterday because partly of my proposal that all reviews have to be online. And so there is a portal which fast tracks that. This is extremely very useful. Thank you.
Much, Professor. Professor Kevin Marsh, for your comments, and then after that, we will give an opportunity to Özlem Bishop. We know you do a lot of modeling for drug discovery. We'll give you an opportunity to comment. Professor Kevin Marsh, please.
Yeah, thanks, Moses. Well, I agree with the comments of my colleague from Ghana. I do think there are broader ethical issues here, and it's really important that they're taken into account. But just to return to what you specifically asked me, I agree with Peter. It is essential, clearly, for fast tracking. The danger with fast tracking, of course, is that there isn't capacity or that people cut corners. And the question is how do you strike a balance? In Oxford, I happen to chair the OxTrek, which is the Tropical Ethical Committee, which looks at research connected with Oxford all over the world. We were presented our first COVID protocol last week, and we reviewed it in 3 days. But we did a full review, and we're doing another one yesterday, which we'll have done by Monday. It is possible, but it takes a lot of effort, and the question is capacity. But even if the ethical committees came up to speed, there is the issue of multi-country studies. We just can't, I think, we can't afford the situation which we're all familiar with, where if you've got a 5-country study, it's got to go through 5 ethical committees. And that's why I was suggesting, I'm interested in people's comments on this, on the acceptability of convening not an advisory group, as was suggested, but an actual, as it were, ethical, a group of ethicists drawn from across Africa and elsewhere to function over the next few months as an ethical committee, do very rigorous reviews, and then for other ethical committees in country to look at the output of that review, obviously, and have the ultimate say, but essentially to accept the review rather than to go through the entire mechanism again. Now, I know that, but there are precedents for this. There are, committees do have cross acceptance, but I really wonder whether we need to establish quickly a Pan-African ethical grouping to review proposals, and it would be a full-time job. I mean, really, there are going to be so many protocols that it could potentially be a full-time job. So I'd be interested in people's views about this. I know not everyone's comfortable with this kind of idea.
Thank you so much, Kevin. Özlem. Okay, then, so we go to Christine Peterson, if you're ready to ask your question or give your comment. Christine.
Great. I'm Dr. Christy Peterson from the University of Iowa. First, if he made it onto the call, I'd like to say greetings to Dr. Christian Happy. I got to work with my wife at Harvard about 25 years ago. My main comment would be, based on the scale and the of the different talking about, please, that it's so critical to come up with a good way to share your data and have it so that people can have data input across all of these different places that can actually have studies that go institutions. Was just being out by Dr. For data sharing, there are systems to do this. So in the same sort of way, I think it's really critical at this point, before things become crazy, to think about what sort of platform you're going to use to ensure that you really can compare data across all of these different studies in different locations. And then my final little statement, as somebody funded to do transmission and comorbidity studies in multiple sites, should you need any assistance in ecology and epidemiology of infectious disease modeling of transmission, my larger cohort of scientists and modelers are happy to help.
So much for that offer, Christine. Özlem.
Yes, you forgot to unmute me.
Yeah, sorry.
This one. Hi, everybody. This is Özlem from Rhodes University, South Africa. I would like to talk about a little bit antivirals. I absolutely agree with Dr. Tariro. Vaccines will take long time, and we have more chance with antivirals. My suggestion is actually, while looking at antivirals, yes, large-scale screening, drug screening for repurposing is quite important. But we can also do lots of computational modeling, especially I suggest that we need to look at from the human genome side. And we have H3 Africa initiative, we have lots of genome data available. We know that human genome in Africa is different than the rest of the world. So we need to use this information, especially to understand the virus-host interactions. So perhaps one way is now to ask the H Africa researchers to make their genome data accessible, at least for the parts that is related to understand virus-host interaction. So that would be very important to start doing antiviral designs computationally, especially. Thank you very much.
Absolutely. Thank you. Thank you so much, Özlem. In fact, one of the work streams that we are planning, thinking of developing is actually on modeling. And if you ask me, we're already behind on this one. When that opportunity comes, I hope that the data scientists and modelers on the continent will actually start with us in this one. So
sorry,
thank you.
Moses,
thank you so much.
Could I just add to that, if that's okay? I'd just say that, thank you. I think that's really critical. I'd just add, the way we traditionally think of antivirals, we think of small molecules as antivirals, but there's a whole host of additional approaches to antiviral therapy and a whole host of different targets. So I'm really glad that was brought up. So thinking about the genetics, thinking about the host's role as well, host receptors, targeting host receptors is going to be important, as well as thinking about the immunobiology response to the virus. One simple thing that comes to mind is some of the most effective antivirals, and we saw this in the case of Ebola, are antibodies, antibody therapeutics. And some of those can be derived from individuals who are good broad neutralizers. And I think there's opportunities on the continent as this epidemic evolves to start to think about some of the immune responses that will be generated and the potential to develop therapeutics based on those. So really just sort of doubling on what was just commented on, I think there's much more to antivirals than what we're thinking of. Using modeling to identify potential targets, looking at host genetics as well as the host immune response for potential approaches to developing therapeutics.
So I'm looking at the time. We've got 7 minutes to go. And we also have lots of very interesting questions on the line. And one of them that we are particularly liking here is about the economics of it all. I know we are scientists. I also know that we also have social scientists on the line. But we have indeed recorded your question, and we will definitely include it in some of the thinking that we are going to be putting together. Olufemi Adedeji. So thanks again for that comment. So for the remaining minutes, I think I'll give it back to Professor Tom Kariuki. in a way to just summarize for us in terms of way forward, what happens next after this, and what is it that we just need to be aware of going forward. So actually, just before I call in Professor Tom Kariuki, I just like to say that first of all, an apology that we have noticed, albeit late, that the slides did not show as expected. So we apologize for that. They were showing quite okay here. So for those of you that they were bigger than your screens, we apologize for that. And then just to remind everybody that the objectives for this particular meeting were to define the areas of research importance in this effort against COVID-19 outbreak, and then also start the initial thinking about the various work streams of science-based effort that we need to put together, and identify any gaps, whether they are here on the African continent or global gaps that are there against this particular infection, and then where possible, develop some, database or scientific advisory units, or even just have a list of people who are interested. And that's why I would like to insist that if you've got any comment, if you'd like to offer anything, or if you think that you still have a question, please go to the questions tab and just type it out, and we will definitely either get back to you if it is something that we need to get back to you about, or if it is something that is more of a comment and a suggestion, a group that we need to get in touch with, then we can actually do that. So with those few comments, I'll hand it back over to Professor Tom Kariuki.
Yeah, so very briefly is to say, for us, we are very appreciative of the inputs we have received in this webinar. We have taken, a write-up of everything that we have heard, and I think we will be able to summarize everything that has come in. Time is of essence for all of us. And I think it's very, very important that we move forward quickly. Whether it is, as Moses has said, we need advisors, we need resources, we need partnerships to get this moving very, very quickly. Once we have captured some of the key research questions and priorities, we want to move quickly in terms of engaging researchers across the continent who can begin to then provide the data and provide the information and provide the advisory, and to get linked to what we need to move forward. So we will be in touch with you. A few of you, we will propose that we get a small group of people who can, again, as said, be advisors for us as we move forward. And I should mention that there are many of our partners here in Africa, but also partners globally. I want to appreciate the fact that I know there are teams from Welcome and from the Bill and Melinda Gates Foundation who are actually been part of this, DFID and others who actually have joined this webinar. And we have had lots of discussions with them because of the need for us to both get resources and to get the R&D going forward in Africa, both locally, in Africa, but also getting support globally, and then linked on that concerted effort to get this going. So I will stop there and say, yes, you'll hear from us, and we will get in touch as to how we move forward on this agenda. Thank you very much for your participation.
Thank you again, Professor Tom Kariuki, for that. We are seeing a lot of questions and comments coming in. As I had said at the beginning of this particular webinar, that we really want to hear what your comments are on your experiences so far, what you think we need to do as scientists on the African continent. We will definitely record that. So again, just to take the opportunity to encourage you to write to us through this particular medium. And just in case you've got a longer question or something that is, you think you would like to discuss in private, I'm just going to show my email. I'd just like to again thank everybody. We saw fellows of the African Academy of Sciences participate in comments and also questions. And again, we'd like to thank our distinguished presenters and panelists that gave of their time to actually make this webinar a success. Invited guests and partners. We also saw that you logged on and took time to listen and follow fellow scientists and clinicians. Thanks again, policymakers. We also saw some of you on the line. Again, thanks for the questions and comments that we have received. We will definitely put all this together into some form of paper and then share with everybody. So there's the email. In case you've got a specific question or you need to be put in contact with anyone who was either talking on the call or any other organization on the African continent, we can be able to do that for you. Otherwise, thanks so much for attending. We are really excited that you were able to join us. And good morning and good afternoon, good evening to you all. Enjoy your social distancing.